Good afternoon. I'm Captain Ibad Khan. I'm representing the Clinician Outreach and Communication Activity COCA with the Office of Emergency Risk Communication at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA Call, The Path of Yeast Resistance, Drug-Resistant Candida on the Rise. All participants joining us today are in listen-only mode. To view live captions, choose More from your menu bar, choose Language and Speech, then click Show Live App Captions. If you'd prefer to view only the content on the slides without the distraction of seeing the thumbnail view of the gallery of attendees, you may wish to switch your settings to Focus Mode. To enable Focus Mode, once again go to your menu bar, click View, then choose Focus on Content. Free continuing education is offered for this webinar, and instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, all planners, presenters, and moderators must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled product or products under investigational use. CDC, our planners, presenters, and moderator wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception of Dr. Megan Lyman's discussion of several antifungal medications in clinical trials for Candida auris and availability of use under expanded access programs. CDC did not accept financial or in-kind support from ineligible companies for this continuing education activity. CDC complies with applicable federal civil rights laws and does not discriminate based on race, color, national origin, age, disability, religion, or sex. To learn more, visit www.hhs.gov/civil rights. At the conclusion of today's session, participants will be able to accomplish the following: describe the increasing prevalence of resistant Candida species, explain the epidemiology of emerging resistant Candida, outline appropriate testing, including species identification, antifungal susceptibility testing, and whole genome sequencing, and summarize treatment options and resources for resistant Candida species. After the presentations, there will be a Q&A session. You may submit questions at any time during today's presentation via the MS Teams platform. Please note the ability to ask a question during live webinar in MS Teams is limited to the first 1,000 attendees. If you are unable to ask a question during the webinar, you may submit your question after the live session by emailing coca@cdc.gov. Please note we receive many more questions than we can answer during our webinars. If you are a patient, please refer your question to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to welcome our presenters for today's COCA Call. We are very pleased to have with us Dr. Megan Lyman, the Acting Branch Chief in the Mycotic Diseases Branch in the Division of Foodborne, Waterborne, and Environmental Diseases at the National Center for Emerging and Zoonotic Infectious Diseases at CDC, and Dr. Dallas Smith, who's an epidemiologist in the Mycotic Diseases Branch at CDC's Division of Foodborne, Waterborne, Environmental Diseases at the National Center for Emerging and Zoonotic Infectious Diseases. I will now turn it over to Dr. Lyman. Dr. Lyman, please proceed.
Thank you. We're really glad to have the opportunity to share with you information about increases in drug-resistant Candida and this path of yeast resistance that we believe are concerning and important for you to know about. I'll start us out by focusing on echinocandin-resistant Candida auris, and my colleague will then present on fluconazole-resistant Candida parapsilosis. Next slide. And since this was already covered, I won't spend any additional time on the objectives of this session. Next slide. And starting with the basics, typically Candida infections are autoinfections caused by strains that already exist among a person's own flora or microbiome, often in their gut, which can then invade the blood or deep organs or grow out of control in other body sites. So it's often not spread person to person, and outbreaks are rare. Resistance depends on the species, but historically has been fairly low, especially among Candida albicans, which has been the most common species of Candida. Next slide. The Candida auris behaves differently from other species, and these characteristics are what make Candida auris so concerning. It's most often resistant to at least one antifungal, but frequently resistant to more than one. Patient skin remains colonized for a long period of time, and they shed it into the environment, where it can also persist on surfaces for weeks. Because of this, it results in healthcare-associated transmission and outbreaks. And like other species, it can cause invasive infections with high morbidity and mortality. Next slide. And looking at the resistance profile for isolates in the US, tested through the AR lab network, almost all are resistant to azoles like fluconazole. About 15% are resistant to polyenes like amphotericin B, and less than 1% are resistant to echinocandins, which is why this is the preferred treatment. Next slide. But something to keep in mind is that there are currently no official susceptibility breakpoints established for Candida auris. The tentative breakpoints that have been published by CDC are defined based on those for closely related Candida species and expert opinion. But the correlation between these breakpoints and clinical outcomes is not currently known. Next slide. So I'll pause for a quick knowledge check. Candida auris is most often resistant to which type of antifungal? Fluconazole, amphotericin B, echinocandins, or flucytosine? And the correct answer is A, fluconazole. Next slide. The first three cases of pan-resistant Candida auris, which is resistant to all three classes of antifungals, were reported in 2019 in New York. These three cases were unrelated to each other with no epidemiologic links, and each seemed to develop resistance after receiving echinocandin therapy. Extensive screening and environmental sampling found no other pan-resistant strains. So transmission did not seem to be a concern, perhaps because of a fitness cost related to pan resistance. Next slide. But in 2021, there were two independent clusters of pan-resistant or echinocandin-resistant cases, a cluster in Washington, D.C. with 3 cases and a cluster in Texas with 7 cases. None of these patients had received echinocandins previously, so this was the first evidence that transmission of echinocandin or pan-resistant strains was possible. Next slide. Even though echinocandin-resistant isolates only make up less than 1% of all isolates, since that time the number of echinocandin isolates, including pan-resistant isolates, has steadily increased, as you can see in red from data from CDC's AR lab network. And just to keep in mind, this is deduplicated data, so multiple isolates from the same patient were excluded. Next slide. Looking into the epidemiologic characteristics of 93 recent echinocandin-resistant cases between August 2023 and December 2024, we found that 85% of specimens were collected at acute care hospitals and 92% were clinical cases, not from screening swabs, but from clinical specimens, which are most commonly collected in acute care hospital settings and more likely to get susceptibility testing. More than 50% of specimens were from urine, reflecting that low echinocandin levels in urine may promote development of resistance. And 56% had prior echinocandin use documented in medical chart review. Even though there may be limitations in capturing all antifungal exposures and documentation of some antifungal use may not have been available. Even so, this does suggest a mix of resistance developed both on treatment as well as acquired through transmission. Next slide. We have learned a lot about the genomic epidemiology of Candida auris and echinocandin-resistant strains through whole genome sequencing. Candida auris overall demonstrates low genetic diversity within clades. Echinocandin resistance has been detected among all 3 major clades circulating in the US, as you can see on the right. Almost all, 92%, of echinocandin resistant isolates had a mutation in the FKS1 gene. This is the most common gene having mutations associated with echinocandin resistance. And we have identified clusters of multiple echinocandin-resistant isolates in the same geographic area, which were genetically very closely related, suggesting transmission. Studies have also shown that echinocandin-resistant isolates were closely related to other susceptible isolates in the same patient and occurred after echinocandin exposure. This suggesting development of resistance on treatment, not transmission. I do want to note that one major challenge with using whole genome sequencing to detect mutations associated with echinocandin resistance is that whole genome sequencing is often not CLIA validated and cannot be used for patient care. Next slide. So hopefully this information highlights how important laboratory testing is to detect cases of echinocandin-resistant Candida auris and guide patient treatment. Species identification is not always performed for non-sterile specimens like urine or sputum, but doing this can enhance detection of Candida auris and has been successful in detecting cases, sometimes even a first case in a region. But antifungal susceptibility testing is necessary to identify echinocandin resistance and determine the best treatment options, especially among patients not responding to treatment. Whole genome sequencing is a tool that can identify mutations linked to echinocandin resistance, but unfortunately the results are not available to guide patient treatment in many cases. Next slide. Unfortunately, clinical data about antifungal treatment for echinocandin-resistant cases is limited, but I'll outline some options that can be considered. The first is higher doses of echinocandins, which can be considered to achieve higher therapeutic concentrations. A second-generation echinocandin rezafungin has less frequent but high front-loaded dosing, and initial anecdotal evidence suggests it works against echinocandin-resistant C. auris and other echinocandin-resistant Candida. 2 additional newer medications that are available through expanded access programs and show promising results against echinocandin-resistant Candida auris are abrexafungerp and fosmanogepix. So the first, fosmanogepix, is a novel antifungal in phase 3 clinical trials, and abrexafungerp, which is already approved for treatment of vulvovaginal candidiasis, has released data from phase 3 clinical trials. Although there have been some delays in getting, some current delays in getting access to this drug, but hopefully that will not be a long-term issue. Combination treatment of more than one antifungal has shown inconsistent in vitro data, and unfortunately, real-life clinical data is not currently available. So more clinical data is desperately needed to guide recommendations, and just a plug that echinocandin-resistant isolates have been added to CDC's AR bank. Next slide. Infection prevention and control measures for echinocandin-resistant strains are the same as those for all other Candida auris strains. And again, as a reminder, these are basic IPC measures like you see at the bottom of the slide, including good hand hygiene using alcohol-based hand sanitizer, contact precautions or enhanced barrier precautions in nursing homes involving gown and glove use, and thorough cleaning and disinfection using List P products approved for use against Candida auris. However, adherence to IPC measures is even more important for echinocandin-resistant cases to prevent any transmission to others and any subsequent infections that would be difficult or even impossible to treat. Next slide. Another knowledge check question. Are special infection control precautions needed for echinocandin-resistant C. auris? A, no, only standard precautions are needed. B, yes, contact precautions or enhanced barrier precautions are needed, just like all strains of C. auris. And C, yes, but additional precautions are needed for echinocandin-resistant strains above and beyond what is needed for all other echinocandin-susceptible strains. And the correct answer is B, that contact precautions or enhanced barrier precautions are needed just like all strains of C. auris. Next slide. So to summarize, although it's not common, the number of echinocandin-resistant cases is steadily increasing, likely as a result of both resistance developed as a result of antifungal treatment, as well as transmission of resistant strains. And it's important to keep this in mind for testing and treatment decisions and additional incentive to ensure good infection prevention and control compliance to prevent additional spread. Next slide. And I'll finish with one last knowledge check. How does echinocandin resistance develop among Candida auris? A, on treatment due to antifungal pressure. B, resistant strains spread between patients. C, both A and B. And D, neither A or B. And the correct answer is C, both A and B. So now I'll hand it over to my colleague, Dallas Smith.
Thank you so much, Megan. So now we're going to be transitioning from talking about Candida auris to another Candida species called Candida parapsilosis. Next slide, please. So Candida parapsilosis, like most Candida species, causes bloodstream infections, also known as candidemia. Through our emerging infections program surveillance, national surveillance in the United States, we see that Candida parapsilosis is the third most common cause of fungal bloodstream infections, as you can see on the figure to the right. We see these infections that are common in premature neonates, persons with cancer or COVID-19, and also organ transplant recipients. Next slide, please. And so when we think about Candida parapsilosis bloodstream infections, the risk factors are pretty similar to other causes of candidemia. These include previous abdominal surgery, total parental nutrition, fungal colonization, central venous catheters, misuse or overuse of broad-spectrum antibiotics, septic shock, and renal replacement therapy. However, The thing that distinguishes Candida parapsilosis from most other Candida species is that this species can persist on healthcare surfaces and healthcare workers' hands, facilitating spread among patients, which you may be thinking this kind of reminds you of Candida auris. And so Candida parapsilosis can form biofilms, and because it can spread person to person or facility to facility, this can cause outbreaks. Next slide, please. Historically, when we think about Candida parapsilosis, it was mostly susceptible to fluconazole, and we weren't too concerned about antifungal resistance. Next slide, please. And as you can imagine from the title of our presentation, we are seeing the global emergence of fluconazole-resistant Candida parapsilosis, and in some countries, 60% of isolates of Candida parapsilosis are resistant to fluconazole. This is a really nice map showing different levels of resistant rates in many parts of the world, including in North America, including in the United States. Next slide, please. And so over these years from 2012 to 2022, we have seen that at least 16 countries have reported fluconazole-resistant Candida parapsilosis. This is likely a severe underestimation just due to access to the ability to speciate, but also to do antifungal stability testing to see if it is indeed resistant to fluconazole. Next slide, please. And when we think about the clinical impact of this resistance, we see that in some estimates, some data suggest that mortality rates for Candida parapsilosis candidemia cases are twice as high for those with fluconazole-resistant isolates compared to susceptible isolates. And this could be from a variety of reasons, and we'll talk about some specific steps that clinicians can take to be able to decrease this mortality rate. Next slide, please. But before that, I want to talk a little bit about, well, what is driving this resistance, or at least what are the mutations that are leading to fluconazole resistance? And what we see is that most fluconazole-resistant Candida parapsilosis strains often carry a ERG11 mutation. And the ERG11 is a key enzyme involved in the ergosterol biosynthetic pathway, which is a critical component to the functioning of this fungus. Next slide, please. And so we wanted to explore the picture of fluconazole-resistant Candida parapsilosis a bit more in the United States. So when looking through our emerging infections program and looking at the most up-to-date data that we have in 2025, we see that the overall trend of resistance is increasing steadily over the years. You can see that in 2023, we had about 19% of isolates were resistant. In 2025 to date, we almost have 14% resistance. We are still finalizing data for 2024, and so stay tuned for more information. But as you can see from this curve, we are seeing increase in resistance in Candida parapsilosis to fluconazole. Next slide, please. We wanted to investigate this resistance a bit more. And so when we're utilizing this emerging infections program, candidemia surveillance, we saw an increase in resistance in bloodstream infections in 2021 in Atlanta, where some of us are based right now on this call. And what we saw when we looked at the data was that 30%, only 30% of these resistant cases had received prior azole treatment in the prior 30 days. And of course, this is documented azole treatment, so it could have been missed, but this was still a low number that may lead to people thinking this may not have been due to treatment pressure. And so we wanted to explore this rise a bit more. Next slide, please. And so when we look at the epi data, we compared patients who had resistant strains versus non-resistant strains to fluconazole. And we saw that people with resistant strains were admitted to a long-term acute care hospital in the last 90 days, were more likely to be admitted to a long-term hospital in the last 90 days, and were more likely to be mechanically ventilated in the prior 30 days. Next slide, please. But what was more interesting is that we took those isolates that were resistant to fluconazole, and we did whole genome sequencing on several of them. And what we found was that all of these were genetically similar. You can see in the box, the blue box with all of the red little dots, those are all the isolates that were resistant to fluconazole. And you can see they're clustering very close together. And so when we thought about this in the larger context of the rise, this actually suggests transmission of a single resistant strain to not only the same facility, but different facilities in the Atlanta area. And so this is a really big concern for us because not only are we seeing more resistance, it's not actually due completely from prior azole use. We are seeing strains spread, resistant strains spread from facility to facility in regions. Next slide, please. And so we wanted to see, well, is this happening globally? And yes, the answer is yes, it has. And so we have seen healthcare transmission of fluconazole-resistant Candida parapsilosis in many countries around the globe. And this could either be within a facility or between facilities. And I just put some examples on our screen, but this has happened in other countries as well. You can see in Brazil, in Turkey, in France, and several other countries. Next slide, please. And so now I want to talk about 3 actions that clinicians can take to help address fluconazole-resistant Candida parapsilosis in the United States and globally. The 3 I'm going to be talking about includes empiric therapy, 2, species level identification, and 3, antifungal stability testing. Next slide, please. So, first, echinocandins are recommended as the initial treatment for candidemia. When we looked at data from our national surveillance, we saw that around 30% of candidemia is treated first or initially with fluconazole in the United States. And because we're seeing growing azole resistance in Candida parapsilosis, but along with other species as well, including Candida auris, we think that fluconazole is going to be ineffective for many of these infections empirically. We also see that data suggests lower mortality with echinocandins used empirically. And I just want to reemphasize that global guidelines and guidelines by the Infectious Diseases Society of America do recommend echinocandins as initial treatment or as empiric treatment for candidemia. Next slide, please. Number 2, it's critical to be able to speciate or have a species level identification on all Candida isolates that do require treatment. As we just talked about, we are seeing certain species like Candida parapsilosis that are increasingly resistant to antifungals like fluconazole that historically might have been used empirically. Clinicians should be requesting species-level identification on all Candida isolates requiring treatment. And this is because management may change based on the species while you're awaiting antifungal susceptibility testing, which may take a little longer than species identification. And so the species you identify could inform empiric therapy. Next slide, please. And one of the most important aspects of addressing fluconazole-resistant Candida parapsilosis is sending cultures for antifungal susceptibility testing. These results can inform step-down therapy. Hopefully at this point that a echinocandin is being used empirically, but there might be opportunities to step down to fluconazole if it is indeed susceptible. Additionally, public health and clinicians can monitor for antifungal resistance patterns regionally and at a facility level to inform antifungal stewardship, empiric therapy, and interventions to address emerging yeast. Next slide, please. And so I want to pause quickly for a knowledge check question. And so the question is, which of the following is a primary mode of transmission for Candida parapsilosis in healthcare settings? A, airborne transmission through respiratory droplets. B, direct contact with contaminated surfaces or medical equipment. C, Vector-borne transmission via insects. D, transmission through contaminated food and water. Next slide, please. And so the correct answer is B, direct contact with contaminated surfaces or medical equipment. And I just wanted to re-emphasize that Candida parapsilosis behaves differently than most Candida species. We are seeing that it may behave similar to Candida auris, although we do need additional data to see how we can inform infection prevention control. Next slide, please. So that is the end of the presentation about Candida parapsilosis, but I just wanted to make a quick plug for a new service that we are offering here at the Mycotic Diseases branch. We are offering a clinical consult service specifically for clinicians who have questions about fungal diseases, diagnosis, trying to diagnose a fungal disease, or if they need assistance in managing a fungal disease. And so you can reach out to us through our phone number, 404-639-5168, or through our email, fungalconsult@cdc.gov. We will respond within 24 to 48 hours, and we will be able to connect you with mycologists in the United States who would treat these diseases on a regular basis. And this is for Candida parapsilosis, Candida auris, or any other fungal infection, whether it be on the skin or invasive. Next slide, please. And finally, from the fun guys and fun gals here at the Mycotic Diseases branch, we want to wish everyone a happy Fungal Disease Awareness Week. Please help us celebrate and raise awareness of fungal diseases. We have specific themes for each day, and we would really enjoy your engagement with us in terms of raising awareness of fungal diseases. And a special thanks to our colleague here in our branch, Anna Baker, for helping preparing this presentation. So I'm going to turn it back to our moderator at this point.
Presenters, thank you so much for providing this timely information to our audience. We will now go into our Q&A session. Audience, you may submit questions via the Microsoft Teams platform. Again, please note the ability to ask a question during the live webinar is limited by Microsoft Teams to the first 1,000 attendees. If you are unable to ask a question during the webinar, you may submit your question after the live session by emailing coca@cdc.gov. So we're going to start by asking a question about colonization. We have a couple of questions focused on Candida auris colonization. The first one asks, how long can patients remain colonized with echinocandin-resistant C. auris?
Sure, I can answer this one. There is evidence that patients remain colonized with Candida auris for long periods of time, especially those with frequent or prolonged healthcare stays. But there isn't evidence to suggest that echinocandin-resistant cases would be any different, although this specific topic hasn't been studied specifically for echinocandin-resistant cases.
Thank you very much. And like I said, we have a few of these. So a follow-up question to that is, do we have data yet on whether patients colonized with C. auris can be decolonized?
Sure, I can answer this too. That's a great question, and I know one that we are really interested in here at CDC, and I know a lot of people are. But it's really challenging because colonized patients can have multiple negative swabs before having another positive swab. So it's really difficult to determine when someone is no longer colonized and a product or decolonizing strategy was successful. One or two or three swabs we found is not sufficient to show that they are no longer colonized. There is data that high concentrations of chlorhexidine does kill Candida auris, but testing of skin levels often doesn't reach those levels. And as you can imagine, it may not be applied to all colonized body sites. And we have seen that there are facilities using CHG bathing that have had transmission. So in the real world, it doesn't seem to be sufficient to, fully stop transmission and be kind of a magic bullet. But there are many researchers and companies interested in exploring new products, and this is a topic, like I said, that is of a lot of interest to CDC. So hopefully something we'll learn more about in the future.
Thank you very much. Another theme we are seeing in the questions are about states requiring isolates of the two Candida species to be sent to them for further epi-testing, as well as if the Candida parapsilosis is a reportable condition for states.
I can go ahead and jump in on this one. This is Dallas. So the only Canada species that is a reportable, as a nationally notifiable condition is Candida auris at this time. And so Candida parapsilosis is not a reportable or a nationally notifiable disease. We do encourage clinicians to perform antifungal susceptibility testing to see if they are seeing fluconazole resistance, and of course, having a conversation with their local or state health department to inform them of the findings, I think would be very appreciated from local and state health departments.
Thank you very much. Our next question asks, can a patient have both echinocandin resistant and echinocandin susceptible Candida auris?
Sure, I'll answer this. There have been reports of patients that have been colonized with two different clades of Candida auris. And just in general, the skin is colonized with a population of Candida strains, including some that could be susceptible and some that are resistant. There's some research on Candida albicans that shows a mix of strains in different body sites. That a person's colonized with a mix of strains. But when they actually develop an infection, like for instance, vulvovaginal candidiasis, then that site changes to just have one single strain. So that's for Candida albicans. We don't have that data for Candida auris, but imagine the same is probably true. And a patient's selective pressures are also an important factor contributing to what strains they're colonized with. And if those are resistant or not, like if they've been exposed to antifungals. So yes, but I will say for treatment purposes, once someone has had an echinocandin resistant strain, I would consider this a concern for future infections, although even then there's limited data and guidance, obviously, about what to use to treat it.
Thank you very much. We also have, as you can imagine, several questions about resistance specific to treatment modalities. Our first question in that vein asks, when you say there's high rates of azoles resistance with Candida auris, are you referring specifically to fluconazole resistance in C. auris? Is there data for using voriconazole or posaconazole for C. auris?
Usually there's a lot of similarity between fluconazole and voriconazole, so there could be some subtle differences, but I think in general it's safest to, unless you can do susceptibility testing, to assume that it will be resistant to all azoles. But if there are challenges with treatment and you're able to do actual susceptibility testing to look at whether it's susceptible to voriconazole, that's a great option, but more often than not, they are similar.
Thank you very much. Our next question asks, are there specific characteristics that you have found in these antimicrobials that tend to favor resistance?
I can jump in here. And so I think what the question is asking, I want to rephrase it a little bit. Fungi are eukaryotic organisms, and they're really good at adapting and evolving. And so I would actually say the fungi are just able to modify themselves and have these mutations so that they become more resistant to our antifungals. which is a growing problem as we've addressed in both of these presentations today.
Thank you very much. Our next question said that your slides showed that resistance to polyenes is low, but they were not the preferred drug of choice. Could you please elaborate if this recommendation is for all drugs in that class? Or just, I guess they mean amphotericin B or all? Just trying to read more into the question.
Yeah, I can start, Dallas. Obviously, you can chime in too. The amphotericin B is the main polyene that would be used to treat candidiasis, especially these like invasive forms. But it has a lot of side effects and toxicity. So for that reason, it's not preferable. Also, the resistance to amphotericin has changed over time. So it's actually varied quite a bit. So it has been higher in previous years, and it seems that some strains that have lower resistance to amphotericin have had more transmission and are more common at this time. But mostly the reason that it's not a preferred treatment is just because of the side effects and toxicity that it causes.
Thank you very much. We have a few questions specific to healthcare settings. First question asks, in a long-term care setting, how would you define a Candida auris outbreak?
That's a really tough question. And I think it really depends on what's happening locally, which is why we don't have kind of one answer, one simple answer, because it is complicated. In an area where there's never been a case, one case could count as an outbreak and, trigger investigation, screening. In other places where it's common in that area, and maybe there's a lot of Candida auris circulating in the region, they're more likely to kind of have a baseline. So an outbreak may be an increase in detections over their baseline, an increase of clinical infections or bloodstream infections. So it's really an increase from what the baseline is, either in the facility or regionally.
Thank you very much. And it appears we have multiple questions about infection prevention and control. So summarizing them, can you please talk about what enhanced barrier precautions or other infection prevention control modalities you recommend, especially if you can stratify them based on practice setting, if possible?
That's a pretty general question. I will stay for Candida auris. Enhanced barrier precautions are recommended for nursing homes, and contact precautions are recommended for hospitals, acute care hospitals, and long-term acute care hospitals. And this is for Candida auris. For Candida parapsilosis, there are not recommendations for anything beyond standard precautions. It's a pretty common bug, Candida parapsilosis, and our concerns about fluconazole-resistant Candida parapsilosis and the spread are concerning, but we are still exploring, and there's limited data right now. So it may be that in the future there are recommendations for contact precautions or enhanced barrier precautions for Candida parapsilosis, but there aren't current recommendations for that now. Yeah.
Thank you very much. Our next question asks, is the resistance profile for the various Candida in other nations similar to what we are experiencing or observing in the US?
So I can talk specifically about Candida parapsilosis. And so in the presentation, I gave a few examples of just how common or the percentage of isolates of Candida parapsilosis that are resistant to fluconazole. In some countries, they are higher than in the United States. As I mentioned, some countries have up to 60% of isolates that are resistant to fluconazole, while some countries may be lower than ours too. But I will say that we have very robust surveillance of candidemia in the United States. And so we still need to figure out globally what resistant looks like in the absence of maybe routine surveillance of candidemia in general and of Candida parapsilosis.
And the same probably applies for Candida auris. We know that there are echinocandin resistant and pan-resistant strains detected in other countries, but the testing capacity varies in different countries. Antifungal susceptibility testing is not an easy test, and it's not always available, and that's the only way to really, detect these resistance patterns. And also, echinocandins as a medication are often not available in other countries, so that will definitely affect the antifungal pressure that may drive resistance.
Thank you very much. Our next question asks if we are cohorting Candida auris patients, can you share your thoughts on separating patients by echinocandin resistant versus echinocandin susceptible status?
That's a great question. I That's something that I think would require some thinking through. A lot of places don't have a ton of ability to do such nuanced cohorting, and it's something that we, may want to consult with the health department and even us at CDC about, because it could get very complicated. And oftentimes, patients who are screened, all the screens are not necessarily getting susceptibility testing to know if they're echinocandin resistant. And before you started doing that cohorting, you would really want to know someone's status beforehand. And, I think the most important thing is, if there are concerns about transmission, really implementing good infection control to prevent transmission and really focusing on that.
Thank you. And we have time for one last question. And the question looks ahead to the future and asks, can you share your any insight you have on the pipeline approval of medications that are currently either in clinical trials or some stage of development that may help against this sort of emerging issue that we are facing?
I'll just say that I think it's one of the better times for antifungal development. You know, Previously there were not many new medications, and recently there have been multiple ones. So I think we're really lucky to have those as an option and really excited about them. And, the results are very promising. So I guess just to say, very optimistic for that, and hopefully there will continue to be interest. But Dallas, especially considering he's a pharmacist, I definitely want him to weigh in as well.
Yeah, I totally agree, Megan. I think this is, although we can always use more antifungals, this is a promising time in antifungal development. Fosmanogepix, which we're really excited about for Candida auris, is in phase 3 clinical trials. It kind of just started, and so that looks like it's going to be several years away. But I just wanted to mention that we currently have newer antifungals that are FDA approved, maybe not for Candida auris or even candidemia, but thinking through how we can perform clinical trials with those new drugs, like abrexafungerp, for example, I think could be really promising because they have a new mechanism of action. When looking in vitro testing, it looks very promising as well. And so thinking through, well, how can we repurpose the newer antifungals that maybe doesn't have clinical trials yet for candidemia, Candida auris, fluconazole resistant Candida parapsilosis, I think is very exciting to think about. And hopefully we can make pushes to see how well these antifungals hold up in clinical settings.
Great. And with that, I want to thank everyone with a special thanks to our presenters for sharing their time and expertise with us. CDC has fully transitioned from the Training and Continuing Education Online TCEO system that provides access to CDC educational activities for continuing education to CDC Train. If you do not already have a Train account, please create one at www.train.org. All new activities that offer CE from CDC will only be listed in CDC Train. CDC Train is a gateway into the Train Learning Network, the most comprehensive catalog of shared public health training opportunities. This transition will allow you to access non-credit and for-credit educational activities and track your learning, including CE, in one place. Many CDC accredited activities are already listed in CDC Train. The move to one system improves efficiency and makes it easier for learners, CDC staff, and partners to offer and earn CE in one place. You can access and download CE transcripts and certificates in TCEO through the end of 2025. Instructions will be available on both platforms, and a learner support team will be available to answer your questions. All continuing education for COCA Calls is issued online through CDC Train. Those who participate in today's live COCA Call and wish to receive continuing education, please complete the online evaluation and post-test by October 20, 2025 with the course code WC4520R-091825. The registration code is COCA 091825. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation between October 21, 2025 and October 21, 2027, and use course code WD4520R-091825. The fully closed caption video and transcript of today's COCA Call will be available on demand next week at www.cdc.gov/COCA. For more details about this COCA Call and other upcoming COCA Calls, and to subscribe to receive announcements for future COCA Calls, please visit www.cdc.gov/coca/hcp/trainings/index.html. You will also receive other COCA products to help keep you informed about emerging and existing public health topics. Again, thank you for joining us for today's COCA Call, and have a great day.